Well, our wonderful, dear, sweet, wonderful Blackboard is down. UACCB is down. I can't do anything in Blackboard to get anything ready for you guys, but I can record the Intrapartum lecture. So that's what we're going to do. We're going to get started with the Intrapartum lecture and carry on like nobody's tomorrow. All right, first things first, we have, get that out of the way. And then let's go to slideshow. Slideshow from the beginning. Okay, we don't care. Alright, chapter 16, labor and birth processes. There's all kinds of little factors that affect the birth process, and we consider the 5 P's. That's been this way since I learned about labor and delivery, or labor and birth processes. We have the passenger, which is the fetus and the placenta, the passageways, the birth canal, powers are the contractions, position of the mother, and of course psychological responses that the mother may have. So, the passenger can affect labor and delivery by whether or not the baby's head is too big to fit through the mother's pelvic. A baby that weighs 6 pounds can actually be considered too large for the pelvic opening if mama's a very small person and she has a small pelvic opening. So it doesn't necessarily have to be a large baby. It's the way it fits into the actual outlet of the pelvic. So that was mainly the reason that it may have some problems getting out. The fontanelles that are in the head are not the fontanelles, but actually the sutures of the fetal head is what helps the head become more elongated without causing damage to the skull or to the baby in order to fit the head through the vaginal opening. So we have 2 that we really are concerned about as far as suture go and are noted. We call them fontanelles. We have the anterior fontanelle and the posterior fontanelle. The anterior fontanelle is the largest one. It's shaped like a diamond, and it'll close about 18 months after birth. Your little posterior fontanelle is very small. It's shaped like a triangle, and it'll close at 6 to 8 weeks after birth. So, the brain, of course, we talked about in our last lecture on NOB was that the brain actually continues to form for several years after birth up into the adolescence. You may see a lot of molding if the baby's head has to be elongated or she's been in labor for a long time. Sometimes it's because the head doesn't fit and the skull has to elongate more so. Most of the time when they're born with these little football heads, it will resolve within 2 to 3 days, sometimes a little bit longer. But when they come out and they're looking like little football heads, you need to be sure that you reassure the parents that the molding will go away. There is a time when the shoulders will affect the passageway out, but that's really a complication, and we're talking about normal labor. So we're just going to talk about, the size of the head and how it actually elongates and fits through the birth canal. Once the head comes through, usually the rest comes through just fine. Fetal presentation is referring to the part of the fetus that enters the pelvic inlet first. So your presentation is usually, there's 3 main ones: the cephalic presentation, the breech presentation, or the shoulder presentation. And of course, the cephalic is the most occurring, and then the breech, and then the shoulder. Shoulders are very rare. They're only seen in about 1% of the births. So presentation would be, are they head down or are they butt down? So cephalic presentation, head down. Breech presentation, are they butt first? Is the shoulder presenting, which is just known as shoulder presentation. The presenting part is the part that lies the closest to the os of the cervix. It's the first part of the body you're going to feel when you do your cervical exam. Usually, of course, with the cephalic, hopefully the cephalic presentation, what you feel first is going to be the head and not a cord or any little hand or anything. So usually it's the head. In the breech presentation, you usually will feel the buttocks, although sometimes if they're in a footling breech, you'll feel the foot first. And then, of course, if it's a shoulder, you will have your presenting part is the scapula. Fetal lie is a little bit difficult for some of you guys. This is for the relationship of the spine of the fetus to the spine of the mother. So, it's a little bit difficult to actually understand. So, the baby has to stay in a parallel axis along with the mom's spine. So if the fetal spine's not in alignment with the mother's spine, that they're not parallel, if the baby is actually transverse in the tummy and at a right angle, those are things that are very detrimental to the birth. So vaginal birth's not going to occur when the fetus is in that transverse lie. And I think your book has some, I guess not. Evidently they don't have any of the lies. They got the presentation, so they don't really have any of the fetal lie. So basically what you need to know about the fetal lie is that the spine of the baby should line up with the spine of the mother, should run parallel with it. Now the baby can be on the right side or the left side, but it needs to run parallel with it. Fetal attitude is the relationship of fetal body parts to one another. So you have to consider how the baby is in alignment to itself. And with this fetal attitude, you usually want to see the baby in what we call the fetal position, where the chin's tucked inside on top of the chest and the legs are tucked in up on the abdomen and crossed, and the arms are crossed, and this puts the baby in the exact position he needs to be in to come out of the birth canal. So deviation from that causes some problems. If the cephalic presentation, if the head is extended or flexed in a man, and that makes the head diameter larger than the maternal pelvis, we're going to see prolonged labor, maybe even a forceps delivery, and a lot of times cesarean. The biparatal diameter is always measured by the doctor when he does the prenatal care, so that he knows what the possibilities are of the fetal head fitting through the pelvis. So if the head gets extended, then that actually enlarges that diameter and won't be able to fit through. And then fetal position. The presentation or presenting part, of course, indicates the position of the portion of the fetus that's in the pelvic inlet. The position is the relationship of a reference point on the presenting part, the occiput, sacrum, whatever that presenting part is, to the 4 quadrants of the mother's pelvic. And there's an example in your book that shows you some of those positions. I'm trying to think. Your new book is not quite like the old book. And there's some really, I think I have some slides on that. So these are all about the passenger, fetal position. The station that we'll be figuring out, we'll be talking about a little bit later, and engagement we'll be talking about a little bit later. So here in depth, here's the fetal head. Those 2 parietal bones, the 2 temporal bones, these are the skull portions that make up the skull. We've already talked about the anterior and posterior. When you palpate the fontanelles, you can actually determine fetal presentation, position, and attitude. This takes a lot of skill, a lot of experience to be able to do this, and sometimes nurses never actually master this skill. When you palpate the fontanelle, usually the fontanelle that you palpate, if you're palpating a small fontanelle that only has 3 bones or 3 sutures, that's going to be the posterior fontanelle because it's a triangle shape. There's only 3 sides to that. So if you can feel that, you know that the back of the head is in what relationship to the maternal pelvic, to the, actually we go toward, if you can feel it and it's up toward the mons pubis, which means the baby is looking downward, then we know that that baby's presentation is not only cephalic, the position is going to be, if it's straight up and down with maternal, it's just going to be occiput anterior. If we felt those 3 little sutures on the bottom toward the rectum, and the baby's head is facing upward, so the face is facing up toward the ceiling, that would be occiput posterior position because the back of the fetal head would be lying on mother's spine and the baby would be looking up. The occiput posterior position is not a good position to be in for labor. It actually prolongs labor. The occiput posterior position, left or right or straight up, will actually prolong labor because there is not enough pressure on the skull of the fetus to cause the cervix to dilate. And here's just a picture of how it is. So you can see that you have 4 suture, 1, 2, 3, 4, with the anterior. And you really don't want to feel the anterior, and you shouldn't. If that chin is tucked in like it should be, you shouldn't be able to feel the anterior fontanelle unless it's really huge. But if the head is tucked in, it's going to bring this posterior fontanelle more toward the front of the cervix to where you'd be able to feel that one. We already talked about all of that. Lucky you. Okay. This presentation is part of the fetus that's going to enter into the pelvic, and it's going to lead the way out. So just remember there are 3 main presentations. Here we go. Here are our abnormal presentations. I knew I had some stuff on slide that wasn't in your book. Face presentation is really bad. You can see that none of these presentations are going to deliver normally. The face presentation is very unusual to deliver a face presentation or brow presentation unless mother's been a high gravida and she's got a proven pelvic. She's had several babies go through there that blazed the way for this one to come through, because there's just not, the facial part is just not strong and hard like the occiput posterior is back here to shove its way through. And the brow is the same way. The head is not tucked. the chin's not tucked into the chest like it should be, so it's the presenting part, the occiput part, is not in the correct position for a good delivery. Of course, breech is never really a good presentation for delivering. Very few, if any, breech deliveries are done this day and age. Most of them are C-sectioned, and shoulders never ever deliver vaginally. You can see why. You cannot get that baby through that canal. Okay, and so here is a kind of a view from the outside in. You can see that that chin is posterior. It's considered posterior because here's the spine. So its relationship to the maternal body is posterior. So the chin is posterior. And that's how it would look coming in. Okay, so you see chin is anterior, facing upward toward the upper portion of mom's body. So if you drew that into 4 quads, this is going to be your posterior area, and this is going to be your anterior area. Okay, we talked about the fetal lie, and it's basically, I read your book and it was kind of confusing with all the parallel, transverse, this and that. It's just basically the relationship of the spine of the fetus to the spine of the mother. And that should be parallel, should be vertical and parallel. And again, the transverse lie is not good. Ha, I just like this picture. Alright, attitude, of course, is that relationship like we talked about in general flexion. So you see the chin is tucked in, the feet are the legs are tucked in, arms are crossed, and we have the largest portion of the fetal head is going to be from here to this point. So they're in general flexion. Again, the biparietal, we talked about that. And the more extended that head is, the harder it is for that head to get through that birth canal. Okay, so position. We didn't talk, I don't think, adequately about the position. Position is actually the relationship of the presenting part to the 4 quadrants of the mother's pelvic. So, remember I showed you the 4 quads on the other. So you have a left. Now remember when you're doing left and right, it's the mother's left and the mother's right. It's not your right. If you're sitting there looking at mom, you might think it's your left, but it's actually going to be her right. So it's relationship of the fetus to the mother's right and the mother's left. So be sure you keep that in mind or you won't be able to determine that when you have a test question. So left is if the presenting part is on the left side of the mother, or if the presenting part is located on the right side of the mother. O means the occiput is presenting. S is the sacrum, such as the fetal, such as the breech position. M is for your mentum, and SC is for your scapula. So it's either anterior or posterior, which means the baby's either facing downward or upward. And all the fetal positions are usually based on that presenting part. If it's a cephalic presenting part, the occiput is the portion that you're going to be looking at, and it's the back of the baby's head. If the baby's looking upward and the occiput with the posterior fontanelle is lying on the lower pelvic area, then that is considered occiput posterior because the occiput is lying on the posterior portion of mom. If the baby was turned the other way, where the fontanelle was palpable at the upper portion of mom's, around the mom's pubis, and the fetal head is looking, the fetal face is actually looking downward, that's considered OA, or occiput occiput anterior. Now you can make it more precise if the baby's posterior fontanelle is to the left side of the maternal pelvic or the right side of the maternal pelvic. So if it's on the left side of maternal pelvic, it would be LOA. If it's facing downward, and it would be ROA if it were facing downward on the right side. On the other hand, if the baby's facing up and the occiput is on the lower region up against the spine, then the baby is considered to be, if it's on the left side, would be left occiput posterior, right occiput posterior. And the occiput posterior position is a very difficult position to deliver from, and a lot of primips can't deliver from this position. The best thing you can do for these occiput posterior positions is to make sure that the mother moves very frequently, and you position her to where it makes the baby want to get out of the position he's in. The transverse location is when they're looking straight across from the left side to the right side of the maternal pelvic. So, let's take a look at this drawing and see if you understand it. Now, the triangular is the posterior fontanelle. It is on the back portion occiput of the cephalic presentation. The frontal position is where your anterior fontanelle is. So, in relationship, this baby is, if this is where my arrow went, the frontal lobe, the anterior fontanelle, that means the baby's face is right here, and the baby is looking downward. The occiput, the back portion of the fetal head, is in the anterior portion of the pelvic, anterior toward mom, in maternal anterior. He's also on mom's left. You think about it. This is mom's left, this is mom's right. So this is L, O because it's occiput, A because it's in the anterior. So he's in the left occiput anterior position. This one over here, baby's just turned where it's on the right occiput anterior. This is the one I was telling you that's transverse, where the baby's looking this way and the back of the head is this way. So it's actually transverse across that pelvic. And then, of course, if it's straight up and down, it's just simply OA, as long as it's the posterior fontanelle is toward the maternal mons pubic, and the face or the front fontanelle is facing toward maternal spine. Now you can see where this occiput being more solid, if it were down here on this spine, what kind of labor do you think mom would be having? A lot of back pain, because every time she has a contraction, that little hard portion of the baby's head is going to press up against her spine. Okay, so you look at that. Now these are kind of a little bit difficult because they're not, they just make it feel like you may not be looking at the right way. So let's just kind of look and see, because sometimes you may think this is transverse, but this ear is not in the middle, okay? If this was transverse, this ear would have about the same distance on both sides. So we're not going to call this transverse. The baby is facing, it's first of all, let's determine it's in the occiput position, right? It's in the cephalic presentation. It's definitely got the occiput position going on. So we know it's occiput. So we know that that middle's going to be an O. Out of those three initials we have, we know we're going to have the middle's O. So what side of the mother is the baby's back to? The baby's back is toward mom's right side, not her left. Be our left. It's mom's right, so we know that it's R-O. And now we got to determine, is it anterior or is it posterior? Well, the occiput portion of the head is not up against the spine. And the baby's facing more toward the back, looking more downward. So I would say that's probably ROA. So let's see if I was right. Well, just give you these things. ROA means right occiput transverse, so we know that it's not transverse. Although it's hard to tell when you look at that. You have to really look to see where that ear is positioned. And I try really hard to give y'all photos that are easy to discern. So it's either, we know that it's not OT, so it's got to be either OA or OP, and it's ROA. And which presentation could cause prolonged labor? ROA is right occiput anterior, so that's a great position to be in. Occiput anterior, that's a great position to be in. Mentum occiput posterior is not going to be labor because that's going to be a C-section. So prolonged labor is caused by an occiput posterior, left occiput posterior. So that would be C. Good job. Which abnormal presentation occurs most often? You guys can get that. Remember I told you there's 3 presentations and one of them, the second one. You're right, it's breech. Okay, so here again are some where we can do lie and presentation and attitude. I don't ever remember to park my phone. Okay, so this in the middle has got your pelvic divided into your 4 quads. Got your posterior. Now, if you look, your posterior and your anterior, they got them turned a little bit. Looks upside down, but it's not because you're looking down into the pelvis. So remember that with this picture, you're looking down in the pelvis. If you're looking into the pelvis while she's lying on her back, then it's going to be turned the other way. So just remember the anterior is where the pelvic bones join, and the posterior is the spine. Those are things that you have to remember in case they throw one of these on you, because I'm sitting here looking at that going, what? So again, there's your R. You can see the ROP and the LOP. You can see more almost, you can see the face and you see how close the ear is to the back of the pelvic, the pelvis. You can see that. And then the transverse, you can see where that ear is lined up almost perfectly with the line where the pelvics come together. So that's a transverse position. And it's definitely occiput, and the baby's lying on the right side and lying on the left side. So that's fairly easy. The ones that's a little bit hard is to be able to tell if they're OA or OP sometimes. But you can see the difference if you look at these. The ear is not perfectly lined up, so you can tell that's different with the transverse. The baby is looking toward the spine instead of toward the front of the pelvic. So, and of course the baby is in a complete flexion, and I love complete flexion. You don't want the baby to be not in the flexion it should be. And of course I'm going to have to record this just in bits and pieces. Because I don't want it to get too long and not record. So we're going to do it that way. And I can't put anything on Blackboard, so pooey. It'll probably be in the morning before I can get anything on here. Alright, station. Station's almost invisible line. It's a imaginary line that you have to kind of draw in your mind in relationship of the fetal head or the presenting part, which we hope is the fetal head, to those ischial spines, and you can feel the bump of the spines when you go in to do your vaginal exam, and you just have to kind of imagine where that line is and how far above that line is or how far below that line is. So it just measures the degree of descent in there, and it's measured in centimeters. So you're either 2 centimeters. Basically, what we don't really say 2 centimeters above or below, because we do cervical measure in centimeters or slash centimeters. So basically, even though it's measured in centimeters, we don't call it centimeters. We call it -1 for 1 centimeter, -2 for 2 centimeters if it's above that imaginary line. At the imaginary line is considered a 0 station, and then once the baby starts descending past that imaginary line, then it's +1, +2, +3, depending on your doctor. Some of them +3 is crowning, some of them +5 is crowning. So it depends on what your doctor uses for their measurements. So here is a picture of fetal descent, and I like this picture because the baby's so cute. But the ischial spines, you can see they've drawn a little black line around them. So here's your ischial spine. And if you drew an imaginary line between here and here, that's at 0 station. And your book does +3 as being crowning, which most people do. If it's up here to -3, you're usually nowhere close to delivery unless you're a multip. You might be able to deliver. Because sometimes those multips will fool you. This one is a 41-weeker who's in vertex presentation or cephalic. Vertex is the same. And he's at a -2 station. -2, so right here, 1 centimeter, 2 centimeters. And they're saying that the cervix is 10 centimeters dilated. So fully dilated, 10 is considered full dilation. So there really should not be any cervix whatsoever showing here. And I think it's just a pretty cool picture to show you how that really, here's this humongous uterus that was just the size of your fist earlier. Okay, so engagement. We didn't talk about engagement. This is the term that's used to indicate when the largest transverse diameter of that presenting part, the largest portion of that presenting part, has passed through the maternal pelvis into the true pelvis. So the true pelvis, of course, is the portion that starts almost at the circle. The flanged out bones are the pelvis. That's the maternal pelvis. But once that head starts going into the actual circle of the pelvis, that's the true pelvis. It usually corresponds with that 0 station. So it usually occurs weeks before labor when you have someone who's having their first baby, and can happen during labor with patients that are multip. So they could actually not even have engagement, start having contractions, and the cervix start dilating, and engagement not occur until they've been in labor for a little while. So most of your nullipares will do, several weeks before, walk around like they've got a football between or a bowling ball between their legs, and then just right before delivery with our multips or during. So our passageway consists of rigid bony pelvis, the tissues of the cervix, the pelvic floor, the vagina, and the introitus. So it's composed of those 4 things. 1, 2, 3, 4, 5 things. I thought I miscounted. The bony pelvis, of course, is going to be our biggest obstacle to overcome for the baby to get out and into the world. It plays the greatest role, and the size and the shape should be determined by the physician before delivery. And there's several different sizes and shapes of the pelvis. We have the gynecoid, which is our most common. The android, it's shaped like a heart. The true pelvic is shaped like a heart. And then the anthropoid, it's kind of oval. And then the platyploid, it's a flat oval. So the android is the one that's usually going to give you the most trouble. Anything that is got, like it's shaped like a heart, it's not symmetrical. And that pointy part of the end of the heart, or the apex of the heart, and then the fundal part of the heart would make it difficult for the fetal head to come through. Then we have our powers. Although we didn't talk about the soft tissue. Our soft tissue, of course, is going to, it's that stretchy lower uterine segment. We'll just throw that in here. The uterus is composed of the body and the cervix, and when labor begins, we start seeing the cervix begin to efface, which causes to thinning out and dilating. It's going to open to allow the fetal portion to descend into the vagina. So the cervix is actually drawn upward and over the first portion of the fetal head, or butt, if that's what's coming out first. The pelvic floor is muscular, and that structure is going to help the fetus rotate anteriorly as it passes through the birth canal. Soft tissue of the vagina developed throughout the pregnancy until the vagina can actually dilate to accommodate the fetus of all the things that go in it. So, primary powers. Our primary powers are the involuntary contractions that move downward over the uterus, separated by short rest periods, and signals the beginning of labor. So that's basically what a contraction is. These involuntary contractions are, as we talked about in our fetal monitoring chapter 18, determined and described. Frequency, how often do they occur? Duration, how long do they last? Intensity, how strong are they? And we learned that frequency is documented in minutes. We learned that we measure frequency from the beginning of one contraction to the beginning of another. We learned that duration is documented in seconds, and that it is measured from the beginning of the contraction to the end of same contraction. We learned that intensity can be measured only by palpation if you do not have an internal uterine pressure catheter. If you have an internal uterine pressure catheter, then you can measure the intensity in millimeters of mercury or Montevideo units. Most of the time we are determining intensity by laying our hands on the top of the fundus very gently, very lightly, and feeling for the intensity, feeling for how strong it is. Usually you can use your face, go to your chin, and lay your hand on your chin, and that is a mild contraction. Lay your hand on your nose, and that is a moderate contraction. Lay your hand on your forehead, and that is a strong contraction. And anything in between is supposed to be, in between your contractions, should be a resting period for the baby to get reoxygenated. So you want to make sure that you have a good resting tone. So you need to feel through one contraction to the next contraction to see if you've got a good resting tone. Of course, if you have an intrauterine pressure catheter, you will be able to tell in millimeters of mercury, and your resting tone should be 10 to 20. Can also be down to 0. That's okay. I'd rather see 0 than see 20, 25. So let's look at these contractions. You've seen this little strip several times, and we want to count our contractions from the beginning of one to the other. All monitor strips look like this. They may be a different color. They may have a different color ink on them, but they still look like this. These darker lines are minutes. Inside each minute are 10-second blocks, 10, 20, 30, 40, 50, 60. So each one of those blocks inside are 10 seconds. This upper portion of the strip monitors fetal heart rate. You can see this is tachycardia. Baby's running over 160, which is our normal. It's running at 180. And these are all measures of the fetal heart tone. This one down here is uterine contractions. This is the measurement that we use for if we have an internal monitor. These are millimeters of mercury measurements. So if we were wanting to know how frequent these contractions were, we would start. I don't know why the arrow wants to disappear. We would start at the beginning of this contraction, and we would go, there's 1 minute, there's 2 minutes, 10, 20 seconds. So we could say 2 to 2.5 minutes maybe. But let's see what this one is over here. We got 20 seconds there, 1 minute and 20 seconds, and then we got 20 seconds. We got, I think there's a gremlin that likes to play with my arrow. 30, 40, 50. So there's another minute and 10, and so there's 2 minutes. So you'd be safe in saying that is a 2 to 2.5 minute contraction frequency on contractions. So what's their duration? Well, this one, 10, 20, 30, 40, probably with this one and that one might go 50. 10, 20, 30, 40, 50, 60, 70. 10, 20, 30, 40, 50, 60, 70. So your duration is 50 to 70 seconds on your duration. Your intensity, if this was an internal uterine pressure catheter, your intensity in millimeters of mercury would be right up here at, let's see, this is 60, so this would be 80. And then to figure those Montevideo units, you would have to go in here and take your resting tone, which is 20. So you would have 80 minus 20, which would be 60, plus, this one looks like it's on 70 minus 20, which would be 50, plus, and then you would go over here and do this one the same way. And you should have at least a 10-minute span to do your Montevideo units. I hope that helps you a little bit more with the monitor. Now this one is this external monitor. So with it being an external monitor, and I said how strong is that contraction, you're going to look at me and say, I don't know, because I can't lay my hands on her stomach through this exam. So only if you can lay your hands on them with an external can you tell me how strong it is. So, how strong are those contractions? Remember, we just said it was an external one. Right, we must palpate. And what's the frequency? Remember, we had to determine it. Now, I said 2 to 2.5 minutes, so I didn't measure that very first one. So, it was evidently shorter. So, I know I can't do it in seconds, so that gets rid of A and B. And they were definitely a lot shorter than 3 to 4. So I can eliminate everything and get down to the correct answer, C. Alright, our primary powers are going to be responsible for the effacement and dilation of the cervix as well as the descent of the fetus. We've already talked about the effacement. It's that shortening and thinning of the cervix in the first stage of labor. Of course, we haven't gone through all the stages of labor, but we will. And of course, we express it in percentages. Now, effacement again is something that's very difficult to master. It's really, somebody tells you somebody's dilated to 55%, that they're just showing off. You just can't do that. Usually, they're either 100% effaced or they may be 50% effaced. If they're somewhere in between that, they may be 80% effaced, but they're not going to be able to be that accurate. You certainly don't, you usually can't tell if someone's 10% effaced or 20% effaced. Usually when you get to 50% effacement. Now, people who are very, very experienced at it might be able to do that, but it's a little bit difficult to do. And effacement can occur during the weeks before labor starts, because that's basically most of your nulligravidas or nulliparas or nulliprimaps are not going to be able, they're going to, their cervix is going to have to efface totally out before dilation starts. So they're usually at 100% effacement, and their dilation might be 1 to 2 centimeters, and then they will start dilating. Whereas a multip's effacement could be the 40 to 50%, and their cervix could be at 5 centimeters, and they could maybe not even efface totally out until they're close to being complete. Dilation, of course, is the enlargement or widening of the cervix, which is the opening to the cervical opening and the birth canal once it's begun. So let's look at cervical effacement and dilation. The very first one we're looking at, there is no dilation whatsoever. There is no effacement. So you see how thick that cervix is. You can actually feel this cervix pop up. The second one that's right beside it is 100% effaced, but they're only 1 centimeter. So if I were looking at that picture, I would think that that's probably a gravida 1. She's not ever had a baby before because she has effaced 100%, but she's only 1 centimeter. Now, this one, number 3, is showing where the cervix is 100% effaced and dilated to 5. And then number 4 is showing where she's fully dilated to 10 centimeters. Now, nobody gets in there with a tape measure or a tool and says, okay, this cervix is actually completely 10 centimeters. It can actually be 12 centimeters. It's just where they stop to say 10 centimeters is complete. When you no longer feel any cervix, it's 10 centimeters. Basically what it's saying is all the cervix is gone and the baby's head can come through, because we know most babies' heads are bigger than 10 centimeters. So that is just a tool. It's just a guideline. So don't go, oh, I measured that with a tape measure. I got in there and it was really 12 centimeters. That's not how it works. This is where they call the line at 10 centimeters being complete. Okay, we go from 0 to 10. You no longer feel any of the cervix. Full dilation. Completely gone. No cervix whatsoever. Marks the end of the first stage of labor. The oxytocin that is released from the fetal head pressing down triggers the maternal urge to bear down, which is the Ferguson reflex. So So the oxytocin is causing that Ferguson reflex to happen. Then we have uterine contractions that are usually independent of external factors unless we give oxytocin, which would be an external factor. But they are usually independent of any external factors. No matter what you do, you're not going to be able to cause uterine contractions to occur unless you're doing an internal thing like oxytocin. When they get an epidural or if they have a narcotic analgesia, they may decrease temporarily. If you give someone sedate and hydrate and their contractions stop and don't start back up, then they weren't in true labor to begin with. We can use the oxytocin, Pitocin, to increase uterine contractions when we need to. And then we have those secondary powers. So we have primary powers and we have the secondary powers. The secondary powers, those uterine contractions are going to change in character and they are going to become very, very explosive. Mom has that involuntary urge to push. No matter what you do, she can't stop from pushing, even though she tries really, really hard not to. It's just very, very hard not to. That bearing down is going to aid in the expulsion of the fetus. And if they start having bearing down and they're not their cervix is not totally dilated, it's not going to have any effect on that cervical dilation. So they really are very important in getting that fetus out of the uterus. And of course, we have a debate going on with how a woman should push. It's been an ongoing debate because what's been recommended by AWON, which is the organization that does a lot of research and does a lot of studies, has recommended that we do open glottis in short periods of bearing down instead of the traditional take a deep breath, hold it, and bear down for 10 seconds 3 times. So basically when we're doing that closed glottis and prolonged bearing down, that Valsalva maneuver, we are causing fetal hypoxia and subsequent acidosis. Whereas if we do open glottis in short periods of bearing down, then it doesn't affect our fetus's oxygenation quite as much. Remember the little diagram? Maybe you don't, but you need to review it. At the peak of the uterine contraction, the placenta is not perfusing with oxygen, and therefore the fetus is not getting perfused. If mom's holding her breath, we're getting even less oxygenation to that fetus. So the pushing portion can actually cause a lot of hypoxia in a fetus. Okay, I think I'm going to stop this here because I'm afraid we're going to run out of space and time. So let's stop this one and we'll go to part 2 if I can get it to end. One of these days I'm going to actually learn how to use my computer. Alright, over here to the cam studio. Where are you at? We will stop you and we'll come back. This is end of part 1.